Bonjour et bienvenue à notre série Printemps 2022.
Hello and welcome to our CPCOC 2020 C-Series on the well-being of veterans and their families. The goal of the series is to provide education on the evolution of pain management, as well as current best practices in interdisciplinary, evidence-based care. My name is Ramesh Sakraz, CEO and Medical Director at the Canadian Veterans Chronic Pain Centre of Excellence.
I would like to take this opportunity to thank our presenter today, Dr. Franklin King from Massachusetts General Hospital and Harvard Medical School. Dr. King will be speaking on the history and existing research for psychedelics. Thank you all for joining us today. Now I would like to present our moderator for this session, retired Lieutenant General Michel Maisonneuve.
Merci beaucoup, Dr. Zacharias, et encore une fois,
Thank you, Dr. Zacharias, and once again, hello, one and all.
Center of Excellence for Canadian Veterans. Welcome to our second spring seminar on veteran and family well-being. Today, again, there are two streams to choose from, a French language stream and an English language stream. We are doing simultaneous translation so we can serve both streams, and all the support material has been translated. You should also be aware that the presentations and slides are best seen in full screen mode. La présentation aujourd'hui sera en anglais, mais avec traduction simultanée.
Presentations will be in English with simultaneous interpretation and slides in French on the French version. We will be taking on the questions after the presentation. Once again, I'm very happy to facilitate this webinar. Having served for 35 years in the Canadian Armed Forces, I came out, like many, with some injuries that caused me pain. The Canadian Veterans Centre for Excellence in Chronic Pain is conducting research that has already provided help to our veterans with chronic pain, as well as their families and the clinicians who take care of them. Our webinar series is designed to inform on the evolution of pain management methods and current best practices in interdisciplinary evidence-based care. And these webinars are intended for veterans, family members, healthcare professionals, as well as ACC case managers and researchers.
Today's webinar, which will deal with the use of psychedelic-assisted therapies and their potential for treating pain. Notre webinaire d'aujourd'hui traitera de l'utilisation possible de médicaments psychédéliques dans le traitement.
Once again, we will be dealing with psychedelic-assisted therapies. So let me introduce our speakers.
He graduated from the University of Massachusetts Medical School in 2013. Currently, he's the Director of Training and Education at the Massachusetts General Hospital Center for the Neuroscience of Psychedelics. He's also a clinical instructor at the Harvard Medical School in Boston. His primary clinical and research interest is in the use of psychedelic-assisted psychotherapy to treat a variety of chronic psychiatric conditions, including depression and anxiety disorders, and in strategies to optimize these interventions for different patient populations. Sa présentation aujourd'hui traitera des études concernant les médicaments
His presentation will deal with these substances and their application in therapeutics. When we speak of evidence base, here is an example. We examine the possible use of these medications for use of pain. Dr. King will provide insight as to why, describe the class of drugs, their use, and the challenges of their use. So without any further ado, here is Dr. Franklin King.
All right, I'm Franklin King. I am a psychiatrist at Mass General Hospital here in Boston. I work clinically in a variety of different roles, as well as some involvement in our latest research endeavors through the Center of Neuroscience of Psychedelics, for which I'm the Director of Training and Education. And so I'm here today to give you all a talk that hopefully will be sort of an overview of psychedelics and psychedelic medicine, sort of tell you a little bit about the history, about the clinical studies, safety and risks, really important area of this, and then looking forward to the questions at the end of the talk. All right, we have some ground to cover, we'll get going. And first, I like to begin my talks on psychedelics, really sort of asking why are we talking about psychedelics in the first place. So we'll sort of frame the question as to why I'm here. Then talk a little bit about the definitions, the clinical uses, the relevant studies. I'm going to tell you some of the mechanisms or the proposed mechanisms. And then finally, some of the challenges, and I think sort of what the challenges the medical community faces in terms of bringing psychedelics into a very sort of Western-centric medical model that has quite a number of limitations. So first off, what actually is the problem? Why are we talking about psychedelics? I think we're talking about psychedelics because we are in the midst, at least in the United States, of a mental health crisis that started before the pandemic, and these are pre-pandemic numbers, but have only continued to accelerate over the last couple of years. So essentially all ages are showing rising rates of depression and anxiety. We're seeing suicide is on the rise, particularly in younger people. We're seeing drug overdose deaths that really started accelerating during the pandemic, but following a trend over the last 10 years. We're seeing, despite increasing numbers of prescriptions in almost all age groups for psychotropic medications, we're not stemming the tide. And again, this has also sort of really started increasing in 2020 through 2022 with anxiolytics, antidepressants, antipsychotics, all being increased in all ages, particularly in teenagers and adolescents. All right. So this is just more sort of gloom and doom statistics. But essentially, we are in this crisis, and that's really kind of why I think there is so much interest in psychedelics at this point. We've known that psychedelics have this potential to be efficacious tools for treating things like anxiety and depression for a long time. They were researched heavily in the 50s and 60s. The research was shut down, but over the last 10 years, there's really been a significant increase in both interest as well as hope. And that's sort of framed within this larger question. So I just think it's really important to name that. And I think that that itself may actually be a risk because of the intensity of need. We really need to sort of balance safety, particularly in the scenario where the media is hyping psychedelics as these sort of panaceas or these miracle cures. So one thing, if I leave you with one thing today, it's really that psychedelics are not completely harmless. They're not miracle cures and they're not panaceas. I do think they have a lot of promise, but the media hype and the sort of public discourse on them is not necessarily helpful. It's important to push back a little bit on that. Okay. But I do think they offer promise to really radically change the mental health system. And so we'll talk a little bit about how they work and hopefully how to do that safely. So first off, what do psychedelics actually do? We really don't have a definition of what the word means. So it literally translates from Greek to mean mind manifesting, soul manifesting. Greek psyche is really soul more than mind. But what psychedelics are generally thought to do, and really sort of my definition more than any, is they produce a profound change in consciousness. Right? The person taking a psychedelic has a change in consciousness that usually is associated with some deeply personal or even spiritual meaning. All right. There's also this experience of ego dissolution. We'll talk a little bit more about that later on in the talk. But this idea of ego dissolution is essentially the reduction of the felt sense of the self as a discrete entity. Okay, and so people can feel either not part of themselves or they can feel that they've transcended themselves. This is often associated with a feeling of increased connectedness or even identification with either another person, another gender, sometimes an animal or an inanimate object. Okay, so it's complicated, it's difficult to put into words. But this is one of these core features of psychedelics. Okay? And then finally, psychedelics produce this enriched sensory experience, an enriched sort of phenomenal experience. People can experience something called synesthesia, which is perceiving a combination of senses, sort of like tasting color or smelling sounds. I put this down at the bottom here on purpose, because I think the media portrayal, often you'll see in movies, people on LSD or on other psychedelics, really having sort of formed visual hallucinations, thinking that these things are real, which they are not. That's really something that you see in either delirium or psychosis. That's not a feature, or a typical feature at least, of psychedelics. People are aware that what they're seeing is a function of the drug, and it tends to not be a fully formed visual hallucination. It's more of sort of a heightening of visual imagery. There can be some shifts, patterns, things like that. But it's not the sort of person in a drug-induced delirium running around chasing a butterfly that's not there. This is really not a feature of psychedelics. And furthermore, it's really not thought to be probably a primary element through which psychedelics exert their therapeutic effect, which is tied more to this sort of felt sense of connectedness and ego dissolution and transcendence. All right. The way psychedelics seem to work, though, is that they have this durable change over time. And I think that's probably more than anything behind a lot of the hype and the sort of intensity of focus in the world of academia and research now as to how psychedelics might be particularly therapeutic. That these seemingly may not be things that people need to take regularly or at least every day the way many psychotropics do, but rather 1, 2, or 3 psychedelic sessions, usually these will be done monthly in research protocols, lead to these rapid and then sustained reductions in symptoms. At least that's what these small studies have been showing so far. So there's this possibility that there's a really durable change over time, even from a single experience. I think that's going to change, and we can talk about that maybe in the Q&A, as the studies actually become more broadly applied to the general population. But nevertheless, that is what we've seen in studies to date. Okay, so just a little on specific psychedelics, just a bit of a primer. Most of the psychedelics that you've probably heard of are in the class called tryptamines. Okay, so tryptamines are a huge chemical class, and they all share a backbone of serotonin, which is otherwise called 5-hydroxytryptamine. You'll see that abbreviated in this talk as 5-HT, which is serotonin, okay? Psilocybin is the most studied of all of these. Psilocybin is the ingredient in magic mushrooms. NMDMT is DMT. You may have heard of 5-MeO-DMT. This is also sort of the subject of ongoing research now, but we don't have a lot of published data on this. And then finally, LSD, which is technically sort of a subclass within tryptamines. But these are all the sort of the heavyweights. These are the ones that have been mostly studied in this single class. But there's another class, the phenethylamines. The phenethylamines are an even bigger class that's used medically for a variety of different conditions. I've listed some of them here, but certain antidepressants, anti-Parkinson disease agents, drugs that are used in intensive care units as vasopressors, and allergy medications, just a wide variety of medical applications of this class. So most of them actually don't have any psychedelic properties, but some do. And this class, at least the psychedelics in this class, really are understudied at this point. Mescaline is probably the most well-known, but there's really not a lot of research on mescaline. And then the other drug that's in this class, and we'll talk about the PTSD studies for this, is MDMA, which really is the only psychedelic in this class for which we have even a small amount of research at this point. Okay. So how do these psychedelics actually work? So remember, 5-HT, which I've listed here, is serotonin. So the primary effect through which psychedelics work is via the 5-HT-2A receptor, the serotonin type 2A receptor. There's many different subtypes of serotonin receptors in the brain. They generally correspond to different parts of the brain or different networks of the brain. This is one particular receptor that's actually seen all across the cerebral cortex, that sort of top part of your brain. All right, it's loaded with these serotonin type 2A receptors. And this is the mechanism, at least pharmacologically, through which psychedelics work. They turn this receptor on and they lead to a change in the neuron, basically becoming activated. This has been shown because you can block this receptor, and by blocking the receptor before administering something like LSD, which we're looking at here on the right in the graph, you're going to completely prevent the psychedelic effect. So what you're looking here on the right, on the y-axis of this graph is essentially a score of how intense the psychedelic experience is for this participant or group of participants. It's aggregate data. And so the purple line is showing people that were given LSD. It starts 180 minutes in, goes up to 360 minutes. And so these people are scoring highly, and then you see it starts coming down. And then there's 2 lines down at the bottom that are superimposed upon each other. One is in green and one is in yellow. And they look almost the same. And that's because one of them is placebo. So people unsurprisingly scored nothing. And then the other line is showing people that were pre-treated with ketanserin, which is just something that blocks this serotonin 2A receptor. And then they were given LSD. So the people that were given ketanserin first had no effect from the LSD at all. And so that's how we know, and this has been done with a number of other psychedelics, that's how we know that this is at least sort of the primary pharmacological effects. Now, there's a lot of downstream stuff, so I'm giving you a much more simplified explanation. And there's many sort of secondary effects that happen, and researchers are really only beginning to uncover some of the more the nuances of the mechanism here. But without this receptor, you're not going to get the psychedelic effect. All right. So safety and physiological effects, the sort of medical effects, the physical effects. So in terms of physical safety or medical safety, psychedelics tend to be fairly safe, and they tend to be fairly well medically tolerated, which is interesting. When you're doing research with new drugs, usually the thing that you're going to be really concerned about is medical safety, liver, seizures, heart, things like that. Psychedelics, for most people, not all, and I can't stress that most highly, are very physically well tolerated. And so the side effects that people will report in studies usually commonly are sort of a mild to moderate headache, some nausea, and some fatigue. This is not uncommon. About 50% of people in studies will report this at some point, but it tends to not be a major adverse effect in the study. You will see some vital sign changes. And so this is not significant for most people, but there are some for whom this actually could be potentially dangerous. Okay, so mild increases in blood pressure, mild increases in heart rate, and mild increases in temperature. So we're talking about 10 beats per minute for heart rate, 10 millimeters of mercury in blood pressure. So if your blood pressure normally is 120 over 80, then it would go up to 130 over 90, for example. Now, for most people, that's not a big deal. For somebody who has untreated hypertension, that could be a big deal. For somebody who really needs to have their blood pressure well controlled, an older person with heart failure, this would actually be an issue. So there is a definite increase, and there are definitely people who are likely medically actually at risk from psychedelics. So it's important to remember they're not medically harmless, but for most healthy people, they tend to be very well tolerated. This also goes for some medically ill subjects, such as people with terminal cancer. There's some preliminary data with healthy, non-cardiovascularly sick geriatric patients that psychedelics may also be safe. Okay. In terms of toxicity, again, for most people, we actually don't have any toxicity data for humans. So the way we arrive at toxicity information is basically through overdoses. There's a calculated LD50, which means the dose of any substance that would kill 50% of the humans who took such a dose. We actually have never seen that with LSD or psilocybin. Okay, so it probably exists. It's probably a very, very, very high dose. There's been accidental overingestions where people have gotten sick, but they've been non-fatal. Okay. And then finally, no evidence for mutagenic effects, like for people who've taken LSD and then a year later had a child, not taken it while pregnant, but before conceiving, been exposed to it. There's not mutagenic effects of this, and there's no neurotoxicity. And I put this on here for those who are a little bit older in the audience and who were around watching commercials, at least over here in the USA. In the 1960s and early 70s, there were a lot of federal government-sponsored anti-LSD campaigns talking about the fact that people who used LSD ended up having children with mutated chromosomes and abnormal neuron development. All of this stuff actually is not based on science at all. It was complete propaganda. So that has not been seen. Sorry. All right, and this is just showing some of the autonomic effects. The autonomic nervous system is what sort of governs your heart rate and your blood pressure. This is just a picture over here on the left. You're seeing psilocybin. Again, that's in magic mushrooms. Slight increase in both systolic, the top number, diastolic, the lower number, with blood pressure, about 10 millimeters of mercury each. Over here on the right, I'm not going to go into detail on this, but this is several graphs looking at escalating doses of LSD. Again, given to healthy subjects, but you're seeing in a dose-dependent fashion an increase in heart rate, an increase in blood pressure, as well as an increase in core body temperature. So again, for most people, this is going to be not a big deal, but for some people who have cardiovascular issues, heart disease, this could be really important to keep that in mind. All right, tachyphylaxis. So tachyphylaxis is a word that refers to when you are administering a drug to someone and it is producing a certain effect, that over repeated administration of the drug, and this can be over days, weeks, or months, that at some point you will fail to actually get the effect of the drug at all, that there's a lockout, and that the drug is no longer producing the effect. And this happens actually quite quickly with psychedelics. And so for most people, and this varies, But for most people, 3 to 4 days of daily administration of a psychedelic, so somebody took LSD 3 or 4 days in a row, there's going to be a complete lockout after that point where they're actually not going to be able to get a psychedelic effect until they stop exposing their brain to the psychedelic for a period of several days or weeks. And then you can get the effect again. All right. And this is interesting. And there's cross tolerance between different agents. So somebody could do daily administration of LSD, and then on day 4, be administered psilocybin, and they would also not get the effect. And it's thought that probably what happens is the serotonin 2A receptor ends up sort of involuting back into the neuron if you overstimulate it too much. But this has basically been seen in animal models. We don't know for sure if this is the mechanism with humans. But there's an implication to this. This is important because what it means is that psychedelics, because one cannot use them every day and continue getting an effect, that it's biologically impossible to actually develop any sort of habitual dependence on them. The way alcohol or a benzodiazepine or cocaine or methamphetamine, all with repeated administration, you might get a diminished effect, but you're not going to get tachyphylaxis. It's actually biologically not possible to have an addiction to psychedelics. Again, that doesn't mean that one cannot have a sort of behavioral consequence to inappropriate use or irresponsible use of psychedelics, or that there cannot be sort of compulsive behaviors around them. But it means that there's not biological addiction that can be generated by psychedelic compounds. Okay. Now, psychological safety. This is the really interesting one, because for most study drugs, you're, like I said earlier, going to be most concerned about medical side effects. But for psychological safety, that makes psychedelics actually quite unique. Most drugs, you're not really worried about sort of the psychological safety quite so much as the psychedelics, but psychedelics are producing such a profound shift in consciousness that really this has to be sort of taken into account when designing a study protocol or when using these. All right. So a variety of things can happen when people take psychedelics. So this doesn't happen to everyone, but it's actually fairly common at some point in the psychedelic experience that something challenging will come up. And that can be anxiety, fear, panic, dysphoria, which is sort of being sort of turbulent and unpleasant emotions, sometimes paranoia, sometimes a psychosis-like state can develop. Right? This can occur across a variety of modalities that I've listed here. It manifests in many, many, many different ways. Now, in clinical settings, which is to say at this point, at least in research clinical settings, the primary intervention that is utilized when this happens is not a medication. So if people are having a panic attack, they're not going to be given something like a Xanax or a medication to stop the panic attack, because this is understood to be a sort of expected potential effect of the drug. And it potentially could actually yield something that could be catalytic or that could be helpful for the person. And so initially, at least, the primary intervention is really interpersonal support. That means that the therapists are going to help talk to the patient. They'll have prepared the patient for this being a possibility. They might help lead the patient in a deep breathing exercise. They might offer supportive touch on the shoulder or the hand. Okay. And this is really sort of primary, secondary, and tertiary intervention. And so in nearly no cases has a medication been utilized in at least contemporary research protocols. Now, occasionally, if the therapist is unable to sort of help the patient, the person's really having a difficult time, or if safety is getting compromised, the person, actually was really sort of paranoid and acting on these thoughts, that would be a situation where medication would be employed. So there's always medications available as backup, but it's just a different paradigm. I think generally in psychiatry, we sort of think about, once symptoms happen, we're going to medicate them, but that's actually quite the opposite here. We sort of expect things to happen, and the role of the therapist is to sort of help guide the patient, help them navigate through this and come out on the other side. That makes sense. Okay. In terms of screening, there are some people that are thought to be at high risk of psychiatric syndromes if they use psychedelics. So certainly anybody who has a psychotic disorder like schizophrenia or a schizoaffective disorder, people who have type 1 bipolar disorder, who've ever had a manic episode, and likely anyone who's had another affective psychosis like psychotic depression. So these are people who would never be allowed into a research study and probably are at risk of really significant destabilization, either mania or psychosis. So these are people that we think really never should be exposed to a psychedelic. It can be quite damaging. A lot of research studies, in the interest of safety, And also because people who have relatives with these disorders are thought to be at increased risk or increased vulnerability of developing psychosis or mania. These people will also be screened out. And so if you have a mother, father, sister, brother, or child who has schizophrenia or bipolar disorder or a history of psychotic depression, those people probably might also be at increased risk. And at least in current contemporary research protocols are usually also screened out. They wouldn't be led into a study for this. Okay. Finally, HPPD. So HPPD is essentially the clinical term for flashbacks, the sort of hallucinogen persisting perceptual disorder, which is something that, I've certainly seen people who've reported this after recreational use. It's not common, but it's not super uncommon. It's long been reported even back into the early days of research in the 1950s. However, what's interesting is HPPD has not been seen, at least to this date, in any research protocols. So it's something that has been seen and reported by patients or by people who've used psychedelics recreationally, but used therapeutically within protocols. We have yet to see a case. So unclear why that might be, but sort of an interesting phenomenal difference here. All right, I just want to tell you a little bit about how the therapy works here. So I probably should have said at the beginning that, I'm talking about psychedelics, but I'm really talking about psychedelic assisted psychotherapy, okay, which is quite different. I'm not talking about psychedelics as they might be used outside of a therapeutic structure. So most of the studies, if not all, in the last 25 years have utilized the paradigm that's shown here in the right column, which was developed in the 1960s on the heels of this earlier model in the left column, which was initially called psycholytic psychotherapy. So we're talking about the 1950s, early LSD research. Psychoanalysis was dominating psychiatry. Psychoanalysis essentially says that patients utilize all these defenses that are unconscious, and the defenses are what impede the therapeutic effect of the psychoanalysis or the psychotherapy. And so people initially thought that low doses of LSD were actually sort of reducing ego defenses and would make the therapy more effective. And so they were using it as a psycholytic to lyse these defenses. And the therapy itself wasn't changed at all. It was basically they were using psychedelics through many sessions. So people might be given LSD for one therapy session a week when they were doing 4 therapy sessions a week. And this would be done over the period of 1 or 2 years. Now, gradually, this tactic changed as there was sort of a growing appreciation in the 60s of indigenous uses and traditional uses of psychedelics, as well as an understanding that psychedelics really put people in a highly suggestive state and seem to work primarily through inducing a sort of transcendent or even a mystical state. And I'll talk about this in a second. And so the idea, instead of just sort of adding psychedelics to an existing therapy model, they reconstructed the whole idea of what the therapy was supposed to do and revolved it around the actual psychedelic. And so this is the model that was developed at the end of the 60s, and this is the model that's generally used today. And essentially, there is a number of preparation sessions which sort of are designed to help the person approach and prepare for the psychedelic experience with equanimity, with openness, trying to reduce expectations and assumptions about what they're going to experience as much as possible. And then following the psychedelic session, usually there'll only be 1 or 2 of these, there'll be a number of integration therapy sessions where the person is supported in basically making meaning out of what they experienced, and sort of processing and trying to understand what happened. Okay? This is very different from the medical model of what most of psychiatry does, at least in this day and age, and what most medicine does, where people sort of come in and ask for an interpretation, and they get a prescription and a diagnosis. Really, one of the primary things within psychedelic therapy or psychedelic assisted psychotherapy is that the therapists are there to support the patient and to help them and to guide them to a certain extent, but they're not there to interpret. They're not there to say, oh, well, you experienced this on psychedelics, that means this, or you should do this. It's really sort of an opportunity to support the person, to look within, to experience this medicine, and to arrive at their own conclusions, their own interpretations. Okay, so this is what I'm talking about when I talk about sort of attention within existing medical paradigms. All right, so a little more psychedelic assisted psychotherapy, or PAP or PAT therapy if you drop the psycho. This is in the 21st century. This is essentially the model. So the therapist is present, but patients are encouraged to have an internal experience. This is not This is not like going to a concert or doing something outside where there's a lot of sort of external focus, looking at things. Persons usually offered eye shades. They don't have to wear them, but most do. And so eyes will be closed for most of the session. There will be a musical playlist that usually is sort of emotionally evocative music, words. The person will be essentially internally focused. Eye shades on, headphones on. They want to talk, the therapists are going to be there, but most of the talking is really going to happen in the preparatory sessions before, the integration sessions afterwards. All right. The room itself, okay, so this is a particularly nice room, but all of the rooms really need to take this idea of set and setting into account. So the environment matters. This is not the kind of thing that you can do in a very sterile hospital room with drop ceilings and fluorescent lights. They tried that in the 60s. A lot of people felt like they were being the victims of medical experimentation. They were in laboratories. The environment is people are exquisitely sensitive to the environment. The setting really does matter. Part of the therapy itself. It's another sort of interesting thing. We don't generally design medical clinics, at least in this day and age, to be particularly nice, soothing, or pleasant. But this is actually a critical element. It's not just something nice to have. It's something that's crucial to ensuring a therapeutic experience, or so it's thought. All right, so we're going to go through a couple of the studies here. I know there's a lot of information, but one thing that's worth mentioning here is that, you know, for all of the hype on psychedelics at this point, there's really not actually that much data, and there's especially little data on so-called clinical populations. So much of the stuff that you've heard about psychedelics in the news are people that aren't they're not studying depression, they're not studying anxiety, they're not studying PTSD, they're sort of so-called healthy normals doing studies. All right, so these studies are small. These are small numbers. All right, so I'm showing you studies here of 20 participants, 27 participants, 59 participants. These are still tiny studies. To get a drug approved, you really need 2 clinical trials of 300 or more patients each for the FDA. All right. So we're still in sort of like, these are small studies, and that means that the chance that we're going to get some different results once we start doing larger ones is actually quite significant. All right. So, but these are basically the 3 studies that we have using psychedelics for depression at this point. So the first was an open label study, so there was no placebo. And they gave people 2 psilocybin sessions. They did find that there was a rapid and sustained reduction in depression scores using the QIDS. It's a measure of depression at the endpoint, which is 6 months later. Okay, so promising, but it was open label. In 2020, this was a Johns Hopkins study, and that's the one that I've shown in the graph in the upper right here. All right, and they took 27 participants with depression, gave them 2 psilocybin sessions. This one was wait list controlled. And what that means is essentially half the people got the treatment immediately, half were put on a wait list for 8 weeks and then given the treatment. So that they were sort of, that's the control. It wasn't placebo controlled. All right, and then what these folks found is that there was about a 50% reduction, or rather 54% of people were in remission by the primary endpoint. So this is actually really, really promising. Right? That may not sound like only half got better, but for a depression trial, that's actually pretty significant. Okay. More curiously is that in 2021, published last December, at the 12-month follow-up, these reductions were largely sustained. Okay, so a year later, this is where you get into this sort of like the appearance of sort of miracle cure. A year later, still about 50% of the people no longer met criteria for major depressive disorder, or major depressive episode, I should say. And then finally, also in 2021, there was this interesting paper that was published where they compared 2 psilocybin sessions to starting patients on S-citalopram. It's an SSRI antidepressant. And what they found is that both patient groups did equally well. So the psilocybin was not superior to an antidepressant, but rather it actually did just as well. And so there's a lot of sort of criticism of this, that, you know, they should have set the primary endpoint a little bit longer out. They only followed them for only 2 months and then stopped. And we all know that there's a heavy placebo response for SSRIs. So we don't know if this efficaciousness that we're seeing with the S-citalopram group might have sort of leveled off over time. How durable the psilocybin effect might have been, another interesting question. And then there were some secondary analyses where the psilocybin group did fare better in terms of well-being But essentially what they had to conclude, their primary measure is basically seeing is psilocybin going to be better than an SSRI. And according to this study, which is the only one that's done a head-to-head comparison, the psilocybin actually was not superior to essentially standard of care. So this is sort of tempering some of the enthusiasm, I think, in the field. All right. Probably in this audience, there's some familiarity with the studies for MDMA, so MDMA-AT or MDMA-assisted therapy for PTSD. This is a series of clinical trials that have been run by an organization called MAPS, the Multidisciplinary Association for Psychedelic Studies. Phase 2 clinical trial, and very small, so only 26 people, published in 2018. That was when I was just finishing up my fellowship year. This was kind of the point. This came out right around the time Michael Pollan published his book. This study got a lot of attention, probably more than it should have, given the size of the sample of only 26 people. But essentially taking people with treatment-resistant PTSD, scoring pretty severely, and then they randomized them to sort of 3 different groups. They used low-dose MDMA as the placebo, all right? And then they sort of did moderate dose and higher dose MDMA. Everybody got 2 sessions of therapy or therapy with placebo. And they found a really significant reduction in CAP scores, and a sizable chunk of the people in this study no longer met criteria for PTSD. All right, so this was very promising. And then they published the first of 2 phase 3 clinical trials that they're doing as part of the FDA approval process of this treatment protocol. So this came out last year, and this was actually a reasonably sized study. So 90 participants. They didn't have treatment-resistant PTSD for this study. They had severe PTSD, so they had to meet a certain cutoff here. For this study, they were given 3 rounds of MDMA-assisted therapy versus placebo therapy, okay? And they found a significant reduction in CAPS, that's basically the PTSD rating scale. It was superior for the MDMA group versus the folks that got placebo. And I'll mention that what's interesting is that the placebo group still gets a lot of therapy. Now, maybe therapy that's designed around the idea of a psychedelic, but there's a lot of therapy hours that go into this. And I'll show you on the next slide, which really sort of brings up a lot of questions of who's going to pay for this? How is this going to be scalable? How is this going to be accessible? All right, so let's tackle the picture on the left here first. This is just showing the placebo group versus the MDMA group. You see the dots are essentially the first, second, and third, or the beginning and then the first, second, and third MDMA session. And you can see that the difference continues to widen, right? So the CAP scores in the red line, which is the folks that got MDMA-assisted therapy, they don't just drop down and stay down, they continue dropping over time, which is interesting. There's sort of an effect that seems to sort of build upon itself. All right, but over here on the right, this funny little diagram, this is just showing how this particular clinical trial protocol worked. And the bands are the different therapy sessions. And so the orange bands, there's 3 of them, are preparatory sessions. Those are 90 minutes to 2 hours each. And then the maroon lines are the 3 MDMA sessions, which are 6 to 8 hours each. So there's 3 of those. And then the green lines are the integration therapy sessions. And those are about 2 hours each. And you see that there's, how many did they do? There's I think 1, 2, 3, 4, right? So this is a huge number of time for both the study participant or the patient, as well as the therapist. And I'll mention that for most of these studies, including the MAP studies, there are 2 therapists for the entire time. All right, so this is, I think the current protocol has 42 therapist hours. So this is going to be a really resource-intensive intervention if this is the way it's going to be. There's a lot of folks that are sort of starting to look at the potentiality of using this sort of in a group format with sort of a lower ratio of therapist to patients in other ways of shortening the experience or reducing the amount of therapist time. But as it is, this is a very resource-intensive treatment. If it were approved today, it would be very difficult to get insurers to reimburse this, particularly for people that haven't had to jump through all the hoops that they usually have to jump through to get treatment that's expensive in psychiatry. So usually you have to get a prior authorization, at least that's how it works in the United States. You have to have documented that didn't respond to all these other treatments and therapies first. So that's probably where things are going to be, assuming the FDA approves it, at least in the beginning stages, until we find better ways of scaling this. Okay. And then finally, psilocybin-assisted therapy for end-of-life depression and anxiety. I think in the interest of time, I'm not going to spend a lot of time on this slide, but this is another really promising area of research. It was looked at a lot in the 60s, right before all the funding was yanked and the research was shut down. But these are entities that are very difficult to treat. So in sort of the oncology world, people at end of life, people facing death from sort of disease, from terminal disease, it's a different phenotype essentially of depression and anxiety than you might see in a clinic that's not related to severe medical illness. And some really promising results from some studies in the 60s that have been replicated in a pair of studies published in 2016, where people got either placebo or a single session of psilocybin-assisted psychotherapy and showed really substantial reductions in both depression and anxiety 6 months out. Okay, so there's a lot of work ongoing right now. So this is the last time anything was published on this was 2016, but in the next few years, the results of a number of studies that are being conducted now are going to be published, and hopefully with similar promising results. Okay, now what's interesting is that the degree of improvement, and this is not restricted just to these studies, generally has been correlated with having a mystical experience. And I mentioned that a little bit earlier, but what is a mystical experience? So these are sort of the defined criteria of a mystical experience. And there's actually a measure for this where you can quantify the degree that someone achieved a mystical experience. And numerous psychedelic studies have actually correlated the degree of improvement, whether it's anxiety, depression, or something else, with the degree that the subject actually had a mystical experience during the psychedelic session. So it's interesting. So this is sort of thought to be kind of a crucial part of psychedelic-assisted psychotherapy. The one exception to this is MDMA. So in the MAP studies, some people do have mystical experiences. They have complete mystical experiences. They cross a threshold on the mystical experience questionnaire. But at least in the studies of using MDMA-assisted therapy for PTSD, the mystical experience is not necessary and it's not correlated with the degree of improvement. Okay, so it may just be that MDMA is a little bit different in the way it works. It may be that PTSD has a different way of recovering that's not as dependent on having mystical experience. But for all the other clinical entities at this point, this idea that we need to achieve a mystical experience in order to sort of really bolster the amount of improvement is sort of one of the ways that we're thinking about this at this point. All right, and I just want to quickly wrap up. I think we only have a couple more minutes before the Q&A, just in terms of the mechanisms, going back a little bit deeper into the pharmacology, in terms of why we might actually be able to have a psychedelic experience. Like, why does our brain have the machinery that if you can take a psychedelic to actually have this happen in the first place? And there's some animal data that shows that the 5-HT-2A receptor system essentially turns on when you stress the organism to a really significant extent. And this has led to a theory that really what might be happening here is that we have the ability in our brain to sort of rapidly unlearn a lot of previously learned things. And essentially what that called on the neuroscientific level is neuroplasticity. And so neuroplasticity means that you're sort of able to make your brain more flexible and to change a lot of previously rigidly held beliefs or ways of thinking or behaviors. And if you can think, there's a lot of sort of theories and interpretations of things like depression and anxiety as essentially being, when you get down to the brain level, being mechanical, right? That they're very ingrained, rigidly held patterns of thinking, particularly thinking about the self. And so by inducing a state of neuroplasticity, we're actually able to sort of unlearn these things. And that may be how they're working. Okay. We see brain-derived neurotrophic factor, which is BDNF. This is a marker of neuroplasticity. This increases after psychedelics. Gipketanserin, which blocks the serotonin 2A receptor. We see that blocking this increase in BDNF. So this is one of the mechanisms by which it works. And then finally, no talk on the mechanisms of psychedelics would be complete without speaking about the default mode network, which is a network of the brain. What I mean, network is different parts of the brain that are not physically contiguous with each other, but are connected very closely in the way they sort of talk to each other normally. The default mode network is closely involved with the sense of self and this idea of self-referential processing. So it turns on when we're sort of thinking and mind wandering and thinking about ourselves. And it's overactive in a number of different psychiatric conditions, particularly in rumination, which we see across a variety of different things, not just depression. And this is the network that is disrupted by psychedelics. There's been a number of different psychedelic studies, psilocybin with LSD, with ayahuasca, and they've all shown disruption of the default mode network. And that seems to correlate with the experience of ego loss, this dissolution of the sense of self. This may be the actual neural signature of what that is. All right, and this show you a million different sort of brain scan pictures, but this is just one showing one part of the default mode network. It's showing decreased functional connectivity after giving subject ayahuasca. It's a Brazilian study. We're going to skip personality factors and just get to challenges, and then we'll do the questions. But coming back to kind of this idea of how psychedelics are thought to be working, it's a really nice article by a Canadian writer, actually, Marianne Apostolides, that I encourage you to Google and read, but really sort of exploring the idea that the way psychedelics have been applied in psychedelic-assisted therapy really is going to be difficult for modern medicine to incorporate, because we have a very sort of rationalist, Western-centric kind of hierarchical approach to knowledge, where essentially, we rely on the randomized control trial. In terms of the way we sort of see patients, we physicians generally sort of look at patients as an aggregate pile of data that we're there to interpret, diagnose, and then prescribe something or do something to the patient. And really, the sort of historic roots of psychedelic-assisted psychotherapy, coming as they do from a lot of non-Western indigenous practices, really actually represent a pretty deep challenge to essentially epistemological ways of how we value who knows and whose knowledge is valuable, and how we arrive at knowing what is valuable. And so I think this is going to be an ongoing challenge to the field in terms of sort of, is this seen as sort of a top-down approach? Are we eventually going to be able to sort of bring psychedelics in and sort of dispense with this current therapy model and make it mimic a more classical medical prescriptive model? Or is the whole medical model going to have to shift significantly to incorporate psychedelics? So I don't necessarily have an answer to that, but I think it's a really interesting piece to consider here. All right, so really encourage this article. It goes into a lot of these things. And finally, I'll just finish. I work as part of a team, some really awesome people, Center for Neuroscience of Psychedelics. You can look us up. We have a small website. Sharman Ghaznavi is starting up the very first psilocybin trial that's ever been done at Mass General. And we have the center headed by Jerry Rosenbaum, who's the former head of our Department of Psychiatry. Some other folks really doing some awesome work. So conclude with that, and then we'll do some questions. So yeah, thank you so much.
Super, merci beaucoup, Dr. King, pour cette excellente présentation. Alors, pour nos
Thank you
auditeurs,
very much, Dr. King, for that excellent presentation. So for those who were listening to us, we had a problem at the beginning, and the question box never appeared. So if you want to ask questions, you can press on refresh, and you'll see the question box reappear.
the question box didn't appear at the beginning, so if you want to do a refresh, then you'll be able to ask questions during the session. So, Dr. King, we very much appreciate your presentation and its possible application to the treatment of chronic pain. Now we're going to go on to questions, and all these have been submitted by our audience. So the first one is, where and how do you think you could apply psychedelic treatment to veterans suffering from chronic pain? Do you think there's potential there for to apply psychedelic treatment to pain?
I do. I think there's potential, but I think, I always want to sort of thread the needle and be careful how I say this, which is why I sort of left out conjecture in my talk. That being said, I'm actually involved in a number of different projects at Mass General right now that if they get going, there's a lot of regulatory stuff, so we're fairly early on, but two of them are specifically looking at pain. So one is looking at fibromyalgia, one is looking at disorders of gut-brain interaction, which encompasses what most people know as IBS, or irritable bowel syndrome. But the underlying idea behind both of these is the same as how I think psychedelics potentially could be helpful for veterans with pain and for chronic pain disorders, which is that we know that chronic pain in general, whichever type of pain we're talking about, has a biological basis, obviously. But that one's relationship with the pain is really a major aspect for many people who suffer from pain. And so there's a question of sort of your psychological relationship with pain, how you identify as someone who's experiencing pain, how you respond to the pain. And all of these are able to be modulated, which is why a lot of, not everybody, but a lot of people who suffer from pain have positive responses and reduction in symptoms to things like cognitive behavioral therapy, or for certain medications that actually work for anxiety and depression. Now, also, we also know that there's sort of direct modulations of things like depression and anxiety and, yes, PTSD. And so people who have a lot of trauma tend to sort of have a different relationship often with their bodies. They experience more intense somatic symptoms. They tend to sort of identify more strongly with negative somatic symptoms or negative physical symptoms. And so I think there's a lot of different potential ways that we could think about impacting pain. So number one, you can take people who have anxiety or depression, treat that, and that would most likely lead to improvements in pain. But there might be deeper ways of modulating the pain. I don't want to go on too long about this, but there was a slide towards the end there where I talked about modulating psychological variables such as neuroticism. And different people who have different personality makeups are more prone to sort of developing more physical symptoms in life and to have more negative responses to that, irrespective of whether there's anxiety or depression. And those personality variables that are more likely to lead to more severe pain syndromes also are those personality variables that we've seen in a number of different studies decrease over time. And this is very interesting because these are personality variables that for most people, at least in theory, once you get to about 30, you're going to score the same on this, whether you're 30 and whether you're 60, whether you're depressed or not depressed. These things like neuroticism, openness to experience, introversion, extroversion, these are stable, but they've actually been shown to change. And so I think modulating these sort of deeper psychological variables also has a lot of promise for a number of different physical symptoms that are very difficult to treat, both by the medical community and within the psychiatric community.
Well, that's very interesting. And a couple of weeks ago, we had the presentations on mindfulness and yoga, which, the tie between the psychological aspects and pain. And so I think you hit the nail on the head there, and certainly I can see the application. At the beginning of your answer, you talked about regulations being an issue, trying to do this next kind of study. And regarding psychedelics, do you think government regulations will hold back the progress being made with applying the findings of this research?
Well, I mean, I have to say, I do think the government regulations are holding back the research. And at the same time, I just want to be very clear that I think the research needs to be done at the pace that research needs to be conducted at. So this is stuff that really you can't rush. These are really powerful compounds. I just can't stress that enough. And I think it needs to be done in a way that's safe. Now, that being said, I think it's very difficult right now to conduct psychedelic research. There's a ton of regulatory stuff. Even if you sort of have all the wherewithal, which takes a long time to get, and sort of how you're going to do this study, it will take you probably about a year minimum in the United States, at least in Massachusetts, to get all the regulatory stuff to start a study. Whereas for a study that's not involving a controlled substance, you could get going much more quickly. And that scares a lot of people away who don't want to get involved or don't want to sort of have the liability. So I definitely think there are things that our governments could do to make the research more easily conducted and to have better, larger clinical trials, which would still take a couple of years to complete, but which I think would be expanding the pool of evidence a lot more quickly than right now.
Okay, and regarding the improvements in mental health brought by psychedelics, how durable are those? Do these improvements do they change? Do they last months, years, or do they revert?
So that's the million-dollar question. I think the studies that have been published to date have shown some very promising suggestions that, at least for certain patients, the improvements will be sustained over the long term. Now, there's a couple of reasons that I don't think that that's probably going to be the case for most people, at least to the extent that we've seen in these small studies. Number one, whenever you sort of conduct an initial study and you have a very small number of patients, you tend to get sort of a much more greatly amplified response And the degree of change tends to sort of shrink the larger the study gets and the more generalized the pool of people that you're studying goes. So that's just sort of a common thing that we see. Number two, a lot of these early studies recruited people who already had a lot of experience with psychedelics. And they also tended to have a huge amount of excitement of people going into the studies. And they had to screen out, like 95% of people who applied to the study, because they're doing a study of like 15 patients. You get 1,000 people applying. And that's not normal for most studies. You don't have like a huge number of people that you have to exclude. And no matter how you try to be sort of unbiased about who gets into your study, you're going to end up cherry picking patients, essentially. And you're going to get people that are more likely to have a much more positive response. So that's a criticism that's been levied, and I think it's a fair one. And then there is some suggestion, there's a number of people that have had positive responses, but then sort of over time, some of the symptoms come back. So I think it's unclear, who's going to respond and for how long. I think the better question, or not the better question, but a really other important question is sort of what sort of things can the medical community do to sort of sustain the effect? So I'm really interested in, how can we make the treatment more powerful? But also, how can people really kind of hang on to these results? So there's a lot of conversation about sort of like community halls and community groups and sort of things that can kind of socially, not necessarily medically, sustain these experiences where people can kind of drop in and talk to each other. And it's thought that that might have some potential. But, a lot of questions can be answered and a lot we don't know.
And now this next question is probably from one of the clinicians listening to us, but understanding that no clinical trials might have been run, what are your thoughts on microdosing psilocybin to treat depression on a cycle of 5 days on or 2 days off?
Yeah, so I mean, I in terms of microdosing, just for those in the audience who don't know, it's using a sub-perceptual dose of a psychedelic. So essentially taking such a small dose that the person taking it wouldn't notice any difference or barely any difference. So like a very small dose, usually about 10% of a normal dose that I was talking about in those studies. There's very little actual good research that's been done with microdosing. So it's difficult to comment on that. It looks like there's likely a high degree of sort of placebo response to that. So they studied some people who were about to embark on I think it was a psilocybin microdosing or maybe an LSD microdosing program. And essentially in this particular observational study, they found that the people that were really excited about it reported a lot of benefit, and the people that were neutral and just doing it for the study didn't really notice any difference. So that's one study, and there's not a lot of other studies to compare it to. But it's difficult to know how much is sort of expectancy versus a biological effect.
Given the effort required to use psychedelics for care, do you see this as second-line treatment, or how should we think about where psychedelics fit into a treatment model?
Well, yeah, I mean, that's another excellent question. I think probably insurance companies, at least, what we have to deal with down here in the States, are going to make it sort of last line treatment just because of the expense of at least the existing models, which require a lot of therapist time. So that may change as we have sort of shorter acting psychedelics, and sort of maybe if we can utilize group models that have less of a sort of intense clinical staff to patient ratio. But if these were approved today, I mean, these are going to be very expensive treatments. So I think that's one of the major challenges here. And for that reason, I think they will be last line treatments. I don't think that treatments that are effective in general should be last line treatments. And I think some things in psychiatry that we tend to treat as last line probably ought to be utilized more quickly for people that have particularly more severe symptoms. But we'll just have to kind of see how it goes.
Okay. A couple of questions here regarding cannabis. So if our veterans, a lot of our veterans are using cannabis, and other people that are having pain as well, but if you're using cannabis currently or other medications, do you have to stop those in order to use psychedelics?
Yeah, so most of the studies up to this point have required that patients taper off pretty much all of their psychoactive medications if they're drinking alcohol or using cannabis or something else regularly. They are asked to stop and sort of taper off that. If somebody's using cannabis once a week, They might let them come in for the dosing day. But again, this is another thing that's like very early on, so we don't know what the impact is of actually having somebody continue. Just when you start, you want to sort of have a very clear drawing board and not have any other sort of chemicals in place. So I can't think of any biological reason off the top of my head that cannabis might prevent the response. But I also think you probably wouldn't want to use cannabis right before being given the psychedelic therapeutically.
Thank you. And our last question is, are psychedelics addictive?
Yeah, so I think I had a slide on that earlier, but what's interesting about psychedelics, most psychedelics, is that you cannot get a psychedelic effect if you take a psychedelic for 3 or 4 days. Most people stop having an effect. So it's actually biologically impossible to become addicted to psychedelics the way you can become addicted to other things. That's a little bit less true with MDMA. There is, particularly in Europe and some of the clubbing culture, there are people who use MDMA about once a week, and that sort of does get people into trouble with some sort of chronic depressive syndromes. And so MDMA is a little bit different in that regard.
Well, Dr. King, thank you very much for your presentation and answers to your questions. Merci beaucoup à vous aussi pour avoir participé.
And thank you, one and all, for having participated. We hope that your research, Dr. King, and the notions that you've shared with us regarding the application of psychedelic drugs to the treatment of stress injuries may one day help in the treatment of chronic pain of our veterans.
Center of Excellence for Canadian Veterans will continue to perform research on the best therapies to deal with, to treat chronic pain, with the aim of bringing hope to all who are suffering and to their families. As you know, we emphasize interdisciplinary services for chronic pain management, where different healthcare professionals work together and share the same philosophy regarding the treatment of chronic pain and teach patients strategies to deal with their condition. Le centre est aussi en train de créer un réseau de
The
cliniques.
center is also creating a network of interdisciplinary clinics from coast to coast that will allow all Canadian veterans to receive a treatment for their chronic pain in an accredited clinic. In these clinics, we encourage a dialogue between the veteran and clinicians to ensure the best care and engagement of the veteran. Remember, help is available and there is hope.
I remind you that a recording of this and all our sessions will be available on our website, and any question you might have can also be asked through our site. Please do not hesitate to contact us for any information you may require. We would also like to get your feedback on these sessions. Do you find them useful from a veteran's perspective or from a clinician's perspective or a case manager's perspective? If you have comments or topics you'd like to hear about, let us know. So this concludes our Spring 2022 webinar series. We hope you'll be with us this fall for 2 more sessions. We'll advertise the dates soon. On behalf of the Chronic Pain Center of Excellence, thank you for your presence. Merci beaucoup à tous et à la prochaine.
And see you next time.